Chapter 10: Chronic Pain and its Treatment. What is pain? No experience rivals pain for its ability to capture our attention and focus our actions. Pain is now considered to be a psychiatric vital sign. An elimination of pain is now recognized as necessary in order to have full symptomatic remission. When acute pain is peripheral in origin but continues as chronic pain, it can cause changes in CNS pain mechanisms that enhances or perpetuate the original peripheral pain. And that's why chronic pain conditions of peripheral origin can be successfully targeted by psychotropic drugs that work on central pain mechanisms. Many other chronic pain conditions may start centrally and may never have a peripheral causation, especially conditions associated with multiple unexplained painful physical symptoms associated with depression, anxiety, and fibromyalgia. Until recently, they were not even considered real. These are now hypothesized to be forms of chronic neuropathic pain syndromes that can be successfully treated with the same agents that treat neuropathic pain syndromes not associated with psychiatric disorders. And these treatments include SNRIs, alpha-2 delta ligands, and other psychotropic drugs. Normal pain and the activation of nociceptive nerve fibers. The nociceptive pain pathway is the series of neurons that begins with the detection of noxious stimulus and ends with the subjective perception of pain. Functional response properties are used to classify primary efferent neurons into three types. A beta fibers detect small movements, light touch, hair movements, and vibrations, while C fibers are bare nerve endings that are only activated by noxious mechanical, thermal, or chemical stimuli. And A delta fibers fall somewhere in between, sensing noxious mechanical stimuli and subnoxious thermal stimuli. Nociceptive pathway to the spinal cord. The primary efferent neurons have their cell bodies in the dorsal root ganglia, located along the spinal column. Nociception begins with transduction. As studied in previous chapters, it is the process by which specialized membrane proteins located on the peripheral projections of neurons detect a stimulus and generate a voltage change, and thus depolarizing neuronal membranes, activating voltage-sensitive sodium channels and triggering an action potential that will be propagated along the length of the axon to the central terminals of the neurons in the spinal cord. The nociceptive impulse flow from the primary efferent neurons into the CNS can be reduced or even stopped when sodium channels are blocked by NSAIDs or local anesthetics such as lidocaine. Nociceptive pathway from the spinal cord to the brain. The central terminals of peripheral nociceptive neurons synapse in the dorsal horn of the spinal cord onto the next cells in the pathway, the dorsal horn neurons, and then project to higher centers, therefore sometimes also called dorsal horn projection neurons. These are the first neurons of the nociceptive pathway that are located entirely within the CNS. Some neurotransmitter systems in the dorsal horn are successfully targeted by known pain-relieving drugs, especially the opioids, SNRIs, and alpha-2 delta ligands. There are several classes of dorsal horn neurons as well. Some receive input directly from primary sensory neurons, some are interneurons, and some project up the spinal cord to high centers. There are several different tracks in which these projection neurons can ascend, which can be crudely divided into two functions. The first one is the sensory discriminatory pathway. In this, the dorsal horn neurons ascend the spinothalamic tract, then thalamic neurons project to the primary somatosensory cortex. This pathway is thought to convey the precise location of the nociceptive stimuli and its intensity. The second is the emotional motivational pathway. In this, the dorsal horn neurons project to brainstem nuclei and from there to limbic regions. This pathway is thought to convey the effective component evoked by the nociceptive stimuli. When these two aspects of sensory discrimination and emotion come together and the final subjective perception of pain is created, we can use the term pain to describe the modality. Neuropathic pain. It is the pain that arises from damage to or dysfunction of any part of the peripheral or central nervous system. Peripheral mechanisms in neuropathic pain. Neuronal damage by disease or trauma can alter electrical activity of neurons, allowing crosstalk between neurons, and initiate inflammatory processes to cause peripheral sensitization. This can hijack normal transduction and conduction in peripheral efferents to maintain nociceptive signaling in the absence of noxious stimuli. Central mechanisms in neuropathic pain. At each major relay point in the pain pathway, the nociceptive pain signal is susceptible to modulation by endogenous processes to either dampen down the signal or amplify it. Segmental central sensitization. This type of neuronal plasticity in the dorsal horn is activity dependent and requires constant firing of the pain pathways in the dorsal horn. The consequence of this constant input of pain is eventually to cause exaggerated or prolonged responses to any noxious input, a phenomenon sometimes called wind-up, as well as painful responses to normally innoxious input called allodynia. and is caused by phosphorylation of key membrane receptors and channels in the dorsal horn, opening the gate to the pain pathway. The gate can also close as conceptualized in the classic gate theory of pain that explains how innoxious stimulus, for example acupuncture, vibration or rubbing, away from the site of injury can reduce the perception of pain. Thus, segmental central sensitization syndromes are mixed states, where the definitive peripheral injuries such as low back pain, diabetic peripheral neuropathic pain, or the painful cutaneous eruptions of herpes zoster is combined with central sensitization at the spinal cord segment. Coming on to suprasegmental central sensitization. This is hypothesized to be linked to plastic changes that occur in the presence of known peripheral causes or even in the absence of identifiable triggering events in the brain sites within the nociceptive pathway, especially in the thalamus and cortex. In the case of pain that originates centrally without peripheral input, it is as though the brain has figured out how to spontaneously activate its pain pathways. And interrupting this process to forget its molecular memories may be a viable approach to treating the hypothesized molecular changes that may underlie disease progression in a wide variety of disorders like SCIS, stress-induced anxiety, PTSD, affective disorders, addictive disorders, and fibromyalgia. The spectrum of mood and anxiety disorders with pain disorders. Pain in the absence of emotional symptoms has long been seen as a neurological disorder. But it is now clear that pain is a symptom that can be mapped onto insufficient information processing within the pain circuits, whether occurring by itself or as part of any number of syndromes, and thus the treatment are same across the spectrum. Fibromyalgia. It is a chronic, widespread pain syndrome associated with fatigue, non-restorative sleep, and tenderness at 11 or more of 18 designated trigger points where ligaments, tendons, and muscle attach to the bone. There is no known cause and there is no known pathology identifiable in the muscles or joints. It is the second most common diagnosis in rheumatology clinics and may affect around 2 to 4% of population. 75 to 90% of patients are women, especially Caucasian. Interestingly, a related syndrome called chronic widespread pain or male fibromyalgia is essentially pain without tenderness, mainly affecting men. Decreased grey matter in chronic pain syndromes. Some reports suggest that chronic pain may even shrink the brain in DLPFC and thereby contribute to cognitive dysfunction in certain pain states such as fibromyalgia and low back pain. Some experts have hypothesized that the persistent perception of pain would lead to overuse of DLPFC neurons, excitatory cell death in this brain region, and thus reduction of the corticothalamic brake of nociceptive pathway, leading to not only reduction of pain perception but diminished executive functioning, sometimes called the fibro fog in fibromyalgia. And thalamic abnormalities could hypothetically be linked to problem sleeping, non-restorative sleep, fatigue, and decreased mental concentration. Descending spinal synapses in the dorsal horn and the treatment of chronic pain. The periaqueductal gray is the site of origin and regulation of much of the descending inhibition that projects down the spinal cord to the dorsal horn. It integrates inputs from nociceptive pathways and limbic structures such as the amygdala and the limbic cortex, and sends output to the brainstem nuclei and the rostroventromedial medulla. Some of these descending pathways release endorphins, which act via mostly presynaptic mu-opioid receptors to inhibit neurotransmission from nociceptive primary efferent neurons. Thus, spinal as well as periaqueductal gray mu-opioid receptors are one target of opioid analgesics. Enkephalins, which act via delta opioid receptors, are also anti-nociceptive, whereas dynorphins acting at the kappa opioid receptors can either be anti or pro-nociceptive. The descending spinal norepinephrine pathway originates in the locus ceruleus, especially from the noradrenergic cell bodies in the caudal part of the brainstem, that is the lateral tegmental norepinephrine cell system. It inhibits neurotransmitter release from primary efferents directly via inhibitory alpha-2 adrenergic receptors, explaining why direct-acting alpha-2 antagonists such as clonidine can be useful in relieving pain in some patients. The descending spinal serotonergic pathway originates from the nucleus raphe magnus of the rostroventromedial medulla, especially the caudal serotonin nuclei that includes raphe magnus, raphe pallidus, and raphe obscurus. It inhibits primary efferent terminals via postsynaptic 5-HT1-BD receptors. And as we have studied previously, these are G-protein coupled and indirectly influence ion channels to hyperpolarize the nerve terminals and inhibit nociceptive neurotransmitter release. But serotonin is also a major transmitter in descending facilitatory pathways, acting via excitatory 5-HT3 receptors to enhance neurotransmitter release. The combination of both inhibitory and facilitatory actions may explain why SSRIs with actions that increase only serotonin levels are not consistently useful in the treatment of pain. One hypothesis for why patients perceive pain when there is no obvious sign of peripheral trauma is that Descending inhibition may not be acting adequately to mask irrelevant nociceptive inputs, leading to perception of pain from what is actually normal input that is ordinarily ignored, such as from joints, muscles and the back in the case of fibromyalgia and depression, and digestion and the GIT in the case of irritable bowel syndrome. If this descending monoaminergic inhibition is enhanced with SNRI, irrelevant nociceptive inputs can once again be ignored and thus no longer perceived as painful. Descending inhibition is also activated during serious injury and in dangerous conflict situations via limbic structures, causing the release of endogenous opioid peptides, serotonin and norepinephrine. This not only reduces the release of nociceptive neurotransmitters in the dorsal horn, but also the transmission of nociceptive impulses up the spinal cord. Interestingly, the placebo effect may also involve endogenous peptide release from these descending inhibitory neurons, since the activation of placebo response to pain is reversible by the mu-opioid antagonist naloxone. However, maladaptive changes can also hijack these mechanisms to inappropriately maintain pain without relevant tissue injury, targeting sensitized circuits in chronic pain conditions. As stated, chronic pain is a marker of an irreversible sensitization process within the central nervous system. When this occurs at the spinal or segmental level, it is likely linked to multiple different neurotransmitters, with each neurotransmitter's release mechanism requiring presynaptic depolarization and activation of N-type and PQ-type voltage-sensitive calcium channels, which is often coupled with the release of glutamate, aspartate, substance P, calcitonin gene-related peptide and other neurotransmitters. And when this occurs at suprasegmental levels in thalamus and cortex, it is likely linked to release mostly of glutamate via the same N-type and PQ-type calcium channels. Blocking these calcium channels with the alpha-2 ligand gabapentin or pregabalin inhibits release of various neurotransmitters in dorsal horn or in the thalamus or cortex. It has proven to be effective treatments for various disorders causing neuropathic pain, and they more selectively bind to open channels and thus be particularly effective in blocking these channels that are most active with a use-dependent form of inhibition causing neuropathic pain, and ignoring those channels that are not open and thus not interfering in normal neurotransmission. Early treatment of pain could interfere with development of chronic persistent painful conditions by blocking the ability of painful experiences to imprint themselves upon the central nervous system, by not allowing central sensitization, and thus could prevent disease progression, thereby improve the chances of reaching full symptomatic remission. Targeting ancillary symptoms of fibromyalgia. The combination of alpha-2 ligands with SNRIs may lead to broader symptom relief than using either alone. That is, alpha-2 ligands may reduce symptoms of anxiety and improve the slow wave sleep disorder. And SNRIs can be useful in reducing symptoms of depression, anxiety, fatigue, as well as cognitive symptoms, since they increase dopamine concentration in DLPFC, which is linked to executive functioning, and thus they can also potentially improve the symptoms of fibro fog, particularly milnacipran at all clinically effective doses and higher doses of duloxetine, venlafaxine and desvenlafaxine. Other strategies to improve fibro fog include the same ones used to treat cognitive dysfunction in depression, including modafinil, R-modafinil, NRIs such as atomoxetine and NDRIs such as bupropion, as well as stimulants with caution. Second-line treatments for pain can include mirtazapine, TCAs, and tricyclic muscle relaxant cyclobenzaprine. Sleep aids can be helpful in relieving sleep disturbances such as benzodiazepines, hypnotics, and trazodone. Evidence is also accumulating for the efficacy of gamma hydroxybutyrate or GHB. It is approved for narcolepsy and enhances slow wave sleep. Other anticonvulsants thought to target voltage-sensitive sodium channels are also used as second line. Experimental treatments include botulinum toxin injections, cannabinoids, NMDA antagonists, and newer anticonvulsants.